according to the findings that were reported in the consensus conference that was held in Chicago in 2024, what are your thoughts regarding, mainly surgical related factors? How should the implants be placed? Should we have any special tendency in terms, let's say, of approaching implants following tooth removal? Should we regenerate more consistently? Should we try to place the implants more frequently in pristine bone using, let's say, either shorter or narrower diameter implants? What are your perspectives in these regards?
Okay, well, thank you, Alberto. First of all, this is Sascha Jovanovic from Los Angeles. My pleasure to be here. And just for those who potentially don't know, my implant career is now almost 40 years, believe it or not. And of course, I've seen my career started with peri-implant disease and studies in that field. And then I have seen a lot of different trends in these decades of implant dentistry. But we're obviously now at a crossroad because there is a large percentage of implant complications which are being seen, and you could just see that in the scientific conferences, how much peri-implantitis is getting attention. So to your question, Alberto, I think that what's is predominantly happening at this moment is that implant dentistry is positioned a little bit too easy and too simple, and that everything has a solution of just kind of, let's make it fast. And we know that implant dentistry, of course, needs really certain things that are very, very important, and it starts from the surgery. So most of the complications that I see over the last decades, probably let's say the last 10 to 15, maybe 20 years, is that implant diameters, first of all, are being used too often, too large. And in the anterior maxilla, lower anterior mandible, there's not enough grafting being done to increase the width. And just a simple calculation already, if we want, and we know that from scientific evidence, 2 millimeters of buccal bone, 2 millimeters of lingual bone, and you have an average diameter of, let's say, 3.75 or 4, you're looking already at 8 millimeters of bone that you need just to be safe. And I think this is what many, many times happens, that implants are being not placed in enough bone. They're being used too wide. They're being placed too buccal. They're being placed too apical. They're in an immediate problem. And then, of course, everything else happens with what Cheyenne said, things happen with restorative, things happen with soft tissues being too thin. But the essence really is that the surgical placement of the implant is many times incorrectly, performed. And often this is considered then not really, in my opinion, a disease. This is a surgical complication. So if we can control this surgical complication from the beginning, I believe that the field of implants and the quality of implants will immediately go up.
Yeah, I do agree. And Cheyenne and myself were discussing also on the critical role that plays the transmucosal component, right? How relevant it is, especially in bone level implants, to develop a sufficient space for the establishment of the supracrestal connective tissue height in order to get far away the inflammatory infiltrate and somehow prevent this early bone remodeling that it seems that, according to the existing evidence, may increase the likelihood to develop peri-implantitis down the road.
Yeah, I believe, I'm a big believer in the research, which, is the one abutment, one time connection. And so that's a really important thing. But again, if we look at it carefully, I was part of the UCLA abutment. And when I was at UCLA, and in the end, the UCLA abutment was not really a good abutment because it didn't fit really well. It was a casted abutment. And it was really one of those early abutment choices that actually created peri-implant bone loss. But then again, when the UCLA abutment was done by prosthodontists who really were taking really, really good care about the precision, the fit, and the surgeons were using implants in good enough bone width, actually the UCLA abutment did really well. So I think it's a little bit the same thing with the connector, or the one abutment, one time procedure. It's a good scientific protocol. But again, it has to be executed in a correct way, because this field, the field of implant dentistry, is all about science, skill, and art. And if we just make it too easy and too quick, and we place too many implants because maybe there's some commercial interest in there, and too close to teeth because you got to squeeze in an implant because this implant is necessary, then we're getting into complications. Again, it's not disease. So I think if we can control this surgical factors to really go back to strong fundamentals, what does it mean to place an implant in good bone? What does it mean to regenerate good bone? How do we protect that implant with a good connector, with good soft tissue? Then I think, the success rate in many, many hands can go up.
Very interesting. Yeah. Actually, Sasha, I have a question for you, and Alberto, for you as well. One of the takeaways of our paper was that, the correct 3D positioning is very important, and perhaps sometimes even more important than biological, factors, systemic factors. And I think what you were saying a while ago is also in line with that. And I'm curious, in your 40 years of career, that you've seen all this shifts of that, and you as well, Alberto, in your extensive research in this and clinical experience, where do you guys see the field going? And where do you see the progression of this? Because more and more people are placing implants, and it's just happening, on a routine basis. So I'm just curious what your thoughts are and where do you think it's going?
Well, I think I had a conversation about this with Danny Boozer. We have been colleagues for like 40 years, and we've been talking about, implant dentistry around the world for a long time. And I think what's currently happening is that there's too many dentists who want to jump into this space. Because to do implants correctly, especially surgically, you need to have experience as a surgeon. That means you have to be, partially a periodontist, you have to be partially an oral surgeon, and then of course you have all the other factors that you need to know about biology and about biomaterials, etc. So I think that we have to accept that everybody is welcome to implant dentistry, but you really need to be trained to be able to place implants in a patient. So not 100% of dentists should be placing implants. So we actually have a number that we came out with, that about 20% of dentists, 20% in general practitioners should be placing implants. Because that means that 1 out of 5 can gain experience, can go to training, can learn from complications, and can improve. But if we have every dentist in the world who wants to place implants because the companies are saying it's so easy, and you could go to a hotel to train and you're going to get some free implants to start or try them out, that's a problem. So I think that's where we need to be a little bit more careful if we want to maintain this high success rate and to stop this potential tsunami of peri-implantitis.
Yeah, I mean, our hope is that peri-implantitis will significantly be reduced over the years, because we have learned so much about all these factors that can be helpful in preventing the disease. However, my expectations differ significantly from that. I do believe that now we're gonna have a very marked divergence in what regards to highly trained and highly educated individuals that are really concerned about preventing this type of diseases and can apply all this knowledge that has been recently provided in the AAP consensus conference. But as you pointed out, Sasha, everyone wants to place dental implants because it turned out to be highly straightforward from a technical perspective. And of course, especially in the emerging countries, they will have to undergo this learning curve, and that may increase the rate of peri-implantitis. So of course, those ones that want to receive a good level of education will significantly have a reduction in the prevalence of peri-implantitis to for sure less than 5%, while those that have to undergo this learning curve or do not care about that because they just care about money, and the short-term success, they will still have peri-implantitis.
Right.
Yeah.
Yeah. Yeah, I think this this consensus conference because I was watching it like, you know, from the sideline. And I'm really, really happy to see the conclusions that you made. And that's a lot of work that you guys put in there. So congratulations with that. And I hope that it will help us to go out and spread the message amongst everybody who cares about implant dentistry and who cares about our patients that, you know, we don't have a tsunami of peri-implantitis. We don't have a high percentage of disease factors here. It's really just controlling and executing and also selecting the right patients, right? Like I remember in the early days of my development, I got involved with a cardiothoracic surgeon, DeBakey. And of course, he was like a very famous surgeon from South Africa. And he had this crazy high success rate. And then like they were asking him like, hey, how do you get to this high success rate in such a challenging surgery? And he said, hey, I just select the patients who I think will be successful. I exclude everybody else. And that kind of comes down to like, you know, where a surgeon should be able to control the factors. And we all have complications. I mean, I have complications. Everybody has complications. But they should go, what you're saying, Alberto, they should go to a minimum, right? Like, you know, if implant dentistry only would be like 50% success rate, we obviously wouldn't be where we are. But like the Brannemark and ITI, of course, they started with a very high success rate. So now it's our task 40, 50 years later to continue this. We should not be going down in success rate. We should be like improving.
Yeah.
Yeah, I fully agree. So I will say that the bottom line of this conversation is that peri-implantitis, first of all, is preventable, even though we all agree that this, we can say, biofilm-mediated inflammatory condition, but are a bunch of predisposing factors that can assist in the onset and progression of peri-implantitis. And in what regards to the implant position, it has to be prosthetically guided. I mean, and we do not need robotic surgery. We do not need to do, let's say, guided surgery in every single case. It's just a matter of simplifying everything, do like an analogic or a digital mock-up, know where the crown should be placed, and that's all.
Yeah, no, I mean, you know, having been involved with like guided surgery for a long time, from the early days of Nova Biocare to now like every single company, I mean, we have to remember that it's really a fine balance between advances being made for the field and for the patient, and then advances being made, you know, to make it easier for more people to get involved because it's commercially beneficial to companies and it's commercially beneficial to individuals. So I think that's very correctly done. And my good friend, also master clinician, Massimo Simeon, he strongly believes that like nobody should be placing implants guided if they don't know how to place an implant correctly without guides. Guides should only help us, you know, like for the purpose of making things more efficient, to make it easier and maybe more precise, but not faster and simpler and quicker and etc.
Okay,
Yeah.
guys. So I thank you. Cheyenne, do you want to add anything else?
No, I was just gonna say that all of these points are great. The only one thing that I hope also happens is that patients, I hope, will also be more educated, because a lot of I mean, if you're a patient and I tell you that you know I can give you a new heart surgery in 1 day, I think most patients will be a little bit skeptical. But when it comes to implants, patients are not skeptical. They think, wow, what a great thing to do. Let me go for that guy who wants to do everything in 1 day. So I hope that, you know, we're talking about a lot of education to clinicians, whether they're specialists or not, but I hope that we can also reach to patients and educate them as well, that, you know, so they could also be able to seek the proper treatment and demand the proper care as well. I hope that also happens from our field.
That's a very good point. And it's also our commitment to educate them.
Yeah.
Yeah, Sharon, I thank you for making that comment. And I think like, I mean, the organizations have done this in the past. And I do think that like, you know, now at this consensus conference, which is very powerful, right? The AAP, the AO, and other organizations, you know, you're looking at now a very powerful, you know, synergy here. So maybe these organizations can come out with, we don't want to obviously like make any negative comments, but maybe we want to educate a little bit the community is look, you know, be more, let's say, informed, be more like, you know, understanding, you know, how much it takes to really do a good implant. And
Exactly.
don't just go for the quick solution, because that quick solution is like, you know, anything which is too good is probably not that good. So
Yeah.
I think that's a very good point.
Yeah, absolutely. Thank you.
Yeah. Okay, guys. So thank you, Sascha. Thank you, Cheyenne. It was a pleasure to share this time with you. I would like also to extend my gratitude to the American Academy of Periodontology, Academy of Osseointegration for this priceless initiative to approach science and to bridge this gap to the clinicians. So thank you very much.